Right, so I'm on here twice, but I need to share my screen here.
So where's the PowerPoint now?
Yeah, so where did you save it to?
Did you oh, I see. It's the same one.
Yeah,
Okay.
in PowerPoint. Yeah, I haven't changed
Yeah,
it.
there's no- It's in this. This one's the top one right there.
Yeah. Okay, perfect.
Themes. Sharing.
And I can see it. Okay, and then I will just like
Can you turn on like just see if this
since it's muted right now.
Yes. Yes. Hey, everybody.
Of course, the dog wanted to go out right on 1 o'clock.
Perfect timing.
Perfect timing, that's right. Sorry, I think we got another minute or so anyway, so till people get here. Maybe give it another minute. Are we expecting everyone today, Anita, do you know?
Yeah, I think so. I mean, I don't know if anyone's on vacation, but otherwise that should be a pretty typical
Okay.
attendance.
Okay, I may just get started then, just so we, okay, somebody's finishing up. Okay, I don't know how long they'll take, and I don't want to cut, too much time off the journal club presentation, so I may just go ahead and get started with my little bit. So let me just share my screen. Okay, can everybody see my screen? I can't see anybody.
we can
Okay. I'm assuming silence means yes. So if you have questions, just feel free to shout out, because I'm just I'm not going to be looking in the chat, and I can't see anybody because I've just turned the video panel off. So we're just going to spend about 10 minutes today talking about t-tests and chi-squared. These come up, of course, very, very often in some of the things that you'll read and some of the research that you'll do. So, what exactly are these tests? So they're both very common, simple statistical tests. And I think it's really important that you understand the key difference between them. So basically, if you're thinking about analyzing continuous data, so like age, BMI, blood pressure, that's a t-test. So a t-test is just a comparison of continuous data, whereas the chi-square is a comparison of dichotomous data. So proportions, like proportion of male subjects, proportion of people with sleep apnea, that kind of thing. So in terms of t-tests, so these are tests that compare the mean, so the averages of a continuous variable in two independent samples. So that's obviously, two different groups of people that are not related. They're independent, and we'll get to some related tests in a little bit. So an example is, do people who sleep less than 7 hours have the same systolic blood pressure as people who sleep 7 hours or more? So the null hypothesis is the hypothesis of no difference, right? It's there's no difference between these groups, although often when you read articles, you don't see the hypothesis written in the null format. So here's a little table here. This shows the mean systolic blood pressure in two groups of people. So we've got people with short sleep. In this case, it was defined as less than 7 hours. And then optimal sleep, which in this case was defined as greater than 7. And you can see here that there's a p-value, right? It's a significant p-value. And we can reject the null, right? Because the p-value is telling us that there is a difference between the two groups. So the blood pressures are different, with the short sleepers obviously being higher. You can see there. So if you have more than 2 groups and you want to do a t-test, you can use an ANOVA instead of the t-test. So basically an ANOVA is an analysis of variance. You can look at like a mean of 3, 4, 5, 5 groups. So it's always a t-test if it's 2 groups. If it's more than 2, think of an ANOVA, right? So for an example of 3 groups is shown there, different, you can divvy up your sleep durations by short, optimal, and long. So what does it tell you? So what it's basically telling you is if the difference in the means that you see between your 2 groups are more than you'd expect to see based on chance alone, then, it will be significant, right? It will tell you if there's a statistically significant difference between the mean score. And then you look at the p-value to interpret that, right? So you can see what the means are, but in order to see if they are statistically significant, look at the p-value. But of course, we've always got to remember that statistical significance does not necessarily equal clinical significance, right? So you can get statistically significant differences in saturation values, for instance, like a 94% versus a 95% if you have big sample. But does that really mean anything clinically? So you've also got to, keep that kind of clinical relevance in mind when you're looking at things. And so there's also a dependent samples t-test. And what that means is you're still comparing the means of a continuous variable in 2 groups, but these groups are dependent on each other. So these could be like the same people before and after an intervention. So that would be a dependent t-test, right? Because you're not having 2 separate groups of people. These are the same people, you're doing an intervention, and then you're looking at whether there's a difference. So an example of this would be, does a night of sleep deprivation have an impact on cardiovascular function, right? So you're looking at the same person, non-sleep deprived and sleep deprived. So that's a dependent samples t-test. So here is just a table to show that. And just for, interest of moving through this quickly, you can see here that in the systolic blood pressure and normal night sleep and sleep deprived, you can see that there was a statistically significant difference between those 2 groups, with the sleep deprived having a higher systolic BP post-exercise. Okay, and that did not happen at rest, because you can see the rest one is here, p-value is here, not significant. So this is like a cheat sheet. This is just like a summary of looking at, your continuous outcomes, so your mean values. So are the observations independent or are they dependent? So if they're independent, you can use the t-test, or if it's more than 2 groups, you can use the ANOVA, and then we get into some other things we're not going to talk about. If they're related to each other, you can use the paired t-test. And then the equivalent ANOVA for a paired is a repeated measures and so forth. So we're not going to talk about all of these different tests, but these are kind of the main ones that you'll see. So let's move on to chi-squared. So you use the chi-square when you want to know if there's a relationship between 2 variables that are categories. So you could say, like I said before, the proportion of male, the proportion of obese, the proportion of hypertension in different groups, that kind of thing. So here's an example. Is the frequency of hypertension higher in patients with OSA than those without? So you've got 2 groups. You've got your hypertension, yes, no. You've got your sleep apnea, yes, no. And you can put these into a table. I'm going to show you a 2x2 table in a minute because they're quite common. But what we see in this example is if we look at those with, so these are all people with a diagnosis of hypertension. And then these are the ones here that have an AHI of 5 or more. So the 72%. So the parentheses is the percentage. And this is the less than 5 AHI, so that was 54%. And what the chi-squared test is doing is comparing these proportions. So it's comparing 72% with 54%, and the corresponding p-value is telling us that there is a statistically significant difference in these 2 groups. Okay, so there's a statistically significant difference between the hypertension and the sleep apnea. Yes, no. So the 2x2 table is something that is actually really important. It's really simple to do if you can remember the order of how you do it. So a 2x2 is basically you have the presence of an exposure, yes, no, and it's important how these fit into the table because you can see they're sort of lettered here, A, B, C, D, so forth. So presence of an exposure, in this particular example, our exposure is sleep apnea. So we have OSA positive, OSA negative. And then we put the presence of your outcome, which in our case is hypertension, along the top here. And again, the order matters. So you put the yes first and then the no second. And then you have this 2x2 table, right? So you've got A, B, C, D cells, and then you've got the total. So you've got an A plus B, C plus D, and then you can do it vertically, right? And if you remember the order, the A, B, C, D order for these, this 2x2 table can do a multitude of things, right? So we're talking about it here in looking at chi-square, but you can calculate odds ratios, you can calculate relative risk, sensitivity, specificity, positive and negative predictive values, and so forth. So if you can put your data into this 2x2, this is a fantastic thing to remember. And you can actually go back to publications that have, you know, the kind of the data that's a raw enough level that you could calculate sort of sensitivities and specificities for things, even if they didn't put that in their manuscript. You can go back and do it using the data if they've supplied these kind of figures. So the chi-squared basically tells you if the observed frequencies that you're seeing in your study of occurrence of the outcome in each group are significantly different from what you would expect. So it's basically a difference of proportions. And you often will see a chi-squared test statistic, which is this one here in the middle. They should really report them, although you will always see many articles that just have the p-value. And again, the higher the chi-squared statistic, the greater the likelihood of finding a significant difference. But of course, you have to look at that p-value to see whether it truly is significant. So just a little caveat with the chi-square is this is sensitive to your sample size. And so when you think about that 2x2 table, you need at least an N of 5 in each of those cells. So if you have less than an N of 5 in those cells, there's a slightly different test that you can do, which is called a Fisher's exact test. So again, this is kind of getting into the weeds a little bit for you, but just to be aware that, you know, there are some caveats to these tests. Similarly to the dependent samples t-test, there is also an equivalent dependent samples chi-squared test, and that's called a McNemar's or McNemar's, I've heard it pronounced. And that's, again, comparing the proportion of a dichotomous variable in samples that are related. So the same group before and after an intervention. So the example there is the proportion of sleep apnea patients with hypertension will be reduced following 6 months of treatment. So in this example, we're looking at the proportion of patients, whereas in the t-test, we were looking at the absolute blood pressure. And there's a cheat sheet for categorical data. So again, the first thing you want to ask are these observations that we're looking at independent? If they are, we do a chi-squared. Are they related before and after? If so, then we do this McNemar's chi-squared test. Okay, and then with that, I will finish. And I will stop sharing. And then we can, if there's any questions, we can do questions, or we can just move on to the journal club. And I can put these in the SharePoint folder as well, so you've got them to refer back to. All right, so we will move on to our journal club article. So I will hand it over to you, Dr. Kokinda.
Thank you so much. And thank you for coming to listen to my journal club. All right, so let me go ahead and share my screen. Are you guys able to see this okay?
We can.
All right, perfect. Okay, so my journal article was on complementary and alternative medicine use in narcolepsy. So I chose this article because I have had a handful of narcolepsy patients that were on high doses of stimulant medication, and we're still reporting a lot of side effects. And so I was curious to see if there was possibly any alternative treatments that they may benefit from. So I ended up finding this article. Okay, so I kind of just wanted to do a general overview on narcolepsy, and this is really mostly for the fellows, since we do have our in-training exam coming up, just to kind of refresh on narcolepsy. So it is a neurological disorder. It is categorized in type 1 and type 2. It was first discovered doing research on canines as well as rodents. Specifically with narcolepsy type 1, there is a loss of hypocretin neurons in the posterior hypothalamus. And if you were to evaluate the CSF fluid, you will see in most patients that they are hypocretin 1 deficient. The literature does suggest that there is an autoimmune mechanism that underlies the destruction of the hypocretin cell neurons in genetically susceptible individuals. And the allele that I came across was HLA-DQB1, which is a specific genetic marker for narcolepsy and is found in almost 99% of cases with hypocretin deficiency. The prevalence of narcolepsy worldwide is 25 to 53 people out of 100,000. And usually the initial symptoms could vary, but excessive daytime sleepiness, cataplexy, specifically in narcolepsy type 1, sleep paralysis, hallucinations, and automatic behaviors, disturbed night sleep are some of the most common symptoms. The evaluation of narcolepsy is pretty extensive. Of course, you do want to get a good family history. You can use questionnaires like the Epworth Sleepiness Scale. Our institution does sleep diaries and actigraphy. I do know that other institutions may not use that, but PSG and multi-sleep latency test is a must. The MSLT should show a mean sleep latency of 8 minutes or less. There has to be at least 2 SORMs, and you can use 1 SORM on the preceding overnight PSG. Optionally, you could get a lumbar puncture and evaluate for hypocretin concentration in the CSF, and the number to remember is less than or equal to 110. And as far as treatment for narcolepsy, there are FDA-approved medications. As you guys are familiar with, Xyrem and Xywav and WakeX. And then, of course, there are the amphetamine-based and non-amphetamine-based stimulants, and then anti-cataplectic antidepressants as well. Fluoxetine, venlafaxine, and atomoxetine are some of those that can be used. And for non-pharmacological treatment, it would be to maintain regular sleep schedules, do scheduled napping and education, as well as treatment adherence. All right, so let's dive into the study now. So the study,
Suzanne,
yes.
I just wanted to make one correction. I think when you're going through the neurobiology, you said that the orexin cells, orexin producing cells are located in the posterior hypothalamus. It's the lateral hypothalamus. Oh,
okay. My apologies.
Just wanted to point that out because that does come up on test questions sometimes.
Okay. I could have been where I found it in a book that I read, but it may have been a little outdated, so I do apologize. Okay, so study rationale. So what the researchers wanted to do was they wanted to determine CAM. So CAM is complementary and alternative medicine. So are the patients using CAM, and to what extent? They also did want to assess what patient profile correlates with higher CAM use, and to determine if using CAM was actually helpful in managing their narcolepsy symptoms. The study was performed in Germany. So within the German population, they did mention that 40 to 62% of the population did accept use of CAM. Which they did mention that it was comparable to other Western nations as well. The most common CAM in this general population in Germany was acupuncture, vitamin and trace elements, as well as medicinal herbs and homeopathy. And then what they did find out was what did influence the use of CAM. So they did look into non-adherence and attitudes toward conventional medications, as well as cost of CAM, since a lot of the CAM is usually paid out of pocket from the patient, and individuals who may not be able to afford purchasing certain CAM, then that also posed a limitation on use. So within the literature, there is no available data so far that analyze CAM use in narcolepsy patients. So this was the first study assessing that. Within the European narcolepsy guidelines, they did mention that more patients were requesting non-pharmacological treatment options for narcolepsy. All right, and how they went about CAM, so they actually classified CAM into 5 different domains, and this was described by the National Center of Complementary and Alternative Medicine, the NCCAM. When I went onto the NCCAM website, it did appear that they may have updated some of the 5 domains. They did mention renaming some of them, but for the purpose of the paper, they did categorize using this standard by the NCCAM, and the 5 domains were alternative medical systems, biological-based therapies, energy therapies, mind and body intervention, as well as manipulative and body-based therapies. I did get this picture from the NCCAM, which I also did discover that they recently did change their name to the NCCIH, which is the National Center of Complementary and Integrative Health. But here's just some examples of some of the domains and what fall into each category. And this was the more recent categories. Okay, so the methods. So what they did was they ended up doing an online survey. They included adult patients, either with narcolepsy type 1 or type 2, which were self-reported. This was cross-checked for conflicting information. So if a patient reported narcolepsy type 1, but then answered no to cataplexy on the questionnaire, then this was excluded. How they reached their patients was through three different ways. The majority of the patients came from 2 outpatient clinics in Witten and in Berlin, which provided approximately 800 patients. And then they also contacted patients through narcolepsy help groups, as well as the German Narcolepsy Network. So they did reach approximately 1,000 to 4,000 individuals total. The survey did include socio-demographic information, as well as disease-related questions and the frequency or impact of CAM in the management of their narcolepsy symptoms. Okay, so the survey did include multiple assessment scales. They did assess sleepiness using the Epworth Sleepiness Scales. In regards to narcolepsy symptoms, they used the Swiss Narcolepsy Scale, which is a tool used to screen individuals specifically with narcolepsy with cataplexy. It does consist of 5 questions. In addition, the patients were asked if they use conventional medications and if they were adherent to that medication. They did assess adherence using the ABQ questionnaire, or the Adherence Barrier Questionnaire. The survey included a total of 69 questions consisting of either yes or no, multiple choice, or Likert scale questions. And then as far as with the narcolepsy questions, it did have information on date and onset of illness, and then an extended symptom checklist. Okay, so the statistics, so I'm just going to summarize the slide because this was from the paper, but just to summarize, they basically looked at means and standard deviations for continuous variables. They used a chi-square analysis to compare categorical variables. They did adjust their p-value since they were comparing, they were doing multiple comparisons. And so because of that, they did have to adjust their p-value. And so their adjusted p-value was 0.0066. And then they did the statistical analysis using this specific software. So any of the questionnaires that came back incomplete, so either if they were missing any sociodemographic information, or if they didn't use CAM, or there was uncertainty of which narcolepsy type, then they did not include those in this analysis. Okay, so results of the study. So they ended up, out of the thousands of patients that they did reach, 272 patients filled out the online survey. Of that, they used 254. 18 of those questionnaires were excluded because there was missing certain data. The average age of the participants was around 35.8. More women than men did participate in the survey. And the mean age for women was around 28 years old. Men was 32 years old. Average Epworth Sleepiness Scale was 16.4. And then the mean disease duration was around 29 years. But the age, so I did mention that the age was 35.8, but it did range very widely between 18 years to 82 years old. All right, so this is just a chart kind of summarizing the sociodemographic and clinical data from these narcolepsy patients. Is there anything in this chart that may stand out to you guys just by looking at it? Or anything interesting in this chart that you can see here? Okay, so what stood out to me was, out of these participants, there was a lot of females that did complete the study. And when I looked at whether narcolepsy was predominant in male versus female, what I did find was that it's, for the most part, it's present for the most part, it is present in both male and female, with a slight preponderance toward male. And I just thought it was very interesting that the majority of the participants in the study was female. I think Roma put something in the comments. Most frequent comorbidity is depression. Yeah, so depression was present in both non-CAM users and CAM users, but there was no statistical significance between the differences between those two. What was interesting on this graph was just below depression was other autoimmune diseases. So it on this graph is showing that patients who have another autoimmune disease, it does show that they have an increase in CAM use from this data set. Also,
what about the education?
yes, so yeah, I was about to get there. So education was also something interesting. So patients who had higher education or higher socioeconomic status were also more likely to use CAM as well.
Because
Yeah,
they're more likely to be able to afford it.
Yes, yes, exactly. Because a lot of CAM can be it can be expensive. And if you're paying out of pocket, then that can be difficult for those who may not have that, for those who may not be able to afford it.
I just want to comment on that. Being from Germany, it's covered by insurance usually, and everybody has insurance.
The alternative treatments are covered?
Yep, homeopathy, everything usually covered by insurance.
So
there's a big debate whether they want to change that, but right now ongoing, but it is covered.
Okay.
Who would have predicted this? I might have predicted the opposite. My naivete.
Mm-hmm. Yeah, it's there's a lot of strong emotions around that.
Sounds like a great place to live.
Different opinions on that, whether it should be covered or not. But for now, it's usually covered. Yeah.
Okay. Okay. I did not know that.
Well, Sonia, I'm sorry. I didn't mean I'm surprised about the coverage so much as the underlying thing. Are you surprised that it's the university educated people who are more likely to use the alternative treatment?
No, not surprised at all. No, no. It's hard to explain, but I think it goes along with other choices, right? That you find maybe more likely in higher, more educated, higher income populations. Yeah. Well, not to get into politics too much,
But if they're using
They do.
CAM, does that mean that they're not using any traditional or they're just using it as adjunct? Maybe I missed that.
Oh, yeah, I will go into it. But they actually did, it was either USACAM or and not with conventional therapies. So they weren't using it in conjunction. It was either CAM or yeah. But that would be a good study though, in the future to assess concurrent CAM with traditional medication versus just traditional medication or just CAM, and to see if there's any difference. All right, so the results. So what they found was that 33% of the patients who reported either present or past CAM use in treating symptoms of narcolepsy, there was no significant difference between narcolepsy type 1 and narcolepsy type 2 patients. About half of the patients who ever used CAM did describe that it was helpful for narcolepsy, with the majority of it being narcolepsy type 1. Of the CAM use, there were 3 that were mostly used by women, and that was yoga, meditation, and art and music therapy. With art and music therapy, there was 0% of patients that were men that used that. Now, within the CAM users, 75% of them used CAM at least once a week versus 23% who used it about once a month. And of the patients who currently did not take conventional pharmacological treatment, 23% reported current CAM use. And then with Dr. Hirschner's comment, there was 27% of the patients used both conventional medicine and CAM, and this was the only reference in the entire paper that they mentioned this, but they never elaborated further on this. So I guess only 27% actually used both. And then just like I pointed out from the table, CAM users were more likely to have a comorbid autoimmune disease than non-CAM users. They did exclude any thyroid disease. Okay, and here are the CAM subgroups, those 5 different domains, and which treatments were within those 5 domains. What I thought was interesting was that vitamins and trace elements was used quite a bit, and also homeopathy. But when I looked a little bit further into what homeopathy was, I did discover that it was first discovered or invented in Germany over 200 years ago. And so it would, the study coming from Germany, I guess it's not as surprising that a large group of people from Germany are using homeopathy. All right, so if out of the 84 patients who did report past or present CAM use, what was interesting is that there were 3 main symptoms that correlated with more CAM use, and that was automatic behavior, hypnopompic or hypnagogic hallucinations, and nightmares. In regards to all the other symptoms like excessive daytime sleepiness or even cataplexy, there was no significant difference between gender and age when using CAM. And here is just to kind of summarize this in a nice graph here. But you can see that within those 3, there was much higher use in CAM. Okay. And they did find that higher education, patients who are retired, and those who have low or no working time, they noticed that they also had higher use in CAM in these types of patients. All right, so now they were comparing whether the patients were adherent to their current medical regimen or not. So what they found was the patients that use CAM at least had one medication regimen change. And this was found in about 75% of the respondents. They were also significantly more likely to have experienced side effects from these medications. And they did mention that dexamphetamines in particular, patients who had previously used these types of medications were more likely to use CAM as well. They also were more frequently not complying with their pharmacological treatment. There was no difference between non-pharmacological treatment, whether they were adherent to that, but it was, they did find that the patients that were more likely to use CAM were not adherent to their current regimen. And then there was no significant difference in regards to disease duration or presence of sleepiness on whether they use CAM or not. So, and then, yeah, so this graph does kind of summarize that. So they, the CAM users at least had one medication change and they experienced side effects. So they was more likely to use CAM. They did say self-reported adherence, but it's not statistically significant. All right, so now so with the adherence, they use that ABQ questionnaire. And so they did mention that 80% of the patients did trust their doctor and they mutually agreed on the treatment plan. However, a lot of CAM users did report having to overcome obstacles in receiving healthcare. Either their pharmacy was too far away or their provider was too far away. So they were more likely to use CAM in that situation. Fear of side effects as well, and costs of CAM use did influence whether they use CAM or not as well. So. All right, so the discussion. So again, this is the first study to assess CAM use in narcolepsy patients, and that the scientific evidence, whether it's effective or not, is limited. The most frequent CAM subgroup was the biological-based therapies, and as like I did mention or point out in the graph, vitamins and trace elements in particular were the most used, along with the second most used subgroup being mind and body intervention, which was predominantly used by women than men, and meditation being the most, and then yoga coming next. This did suggest that perhaps in some of these patients that they may desire more psychological contentment or possibly spiritual contentment as to why they may have chosen meditation and yoga. And with the predictors, higher socioeconomic status, education, were more likely to use CAM. And they did mention that if you were a female with narcolepsy, they noticed that they were more likely to use mind and body interventions, but not as a general predictor as a whole. symptom severity also influence CAM use. Symptoms of nightmares and automatic behaviors, as well as those hallucinations that were more frequently to use CAM. And they did, in the paper, they did mention that this could suggest that our current available medications may not be addressing these symptoms sufficiently. And so they're trying to find an alternative treatment for that. And then willingness to use CAM. So if their medication regimen was changed, if they're experiencing side effects from their current medication, then they were more likely to use CAM. And then poor access to healthcare as well. So some of the limitations to the study, it was an online format, and then diagnostic certainty could not be ensured, but they did do cross-checking and then to try to mitigate whether this was a patient who truly had narcolepsy or not. But again, the certainty there couldn't be any diagnostic certainty. It also did coincide with the COVID-19 period. And so they're not sure if this may have impacted the study in any way. And then overall, there should be larger studies really to confirm the results, perhaps in the future to maybe discuss the motivations as to why patients are using CAM, and for specifically which symptoms that they're using for it. And then as far as treatment durations or types of CAM use, which ones were beneficial, which ones were not. And in the study, they did lump together past and present CAM users. So it would be interesting to see for the past users, why did they discontinue it if they were experiencing any side effects from CAM use? And then, so they, for the conclusion, the data on current treatments may not improve symptoms sufficiently or may cause adverse side effects with the current pharmacological therapy available. So they did also mention that CAM in, when was the study performed? So this study was actually published in 2023. Often females respond to surveys. Yeah. Yes. Okay. Yeah, so yeah, often females provide answer to surveys. Yeah, so definitely on this survey, there was definitely more of a female dominance. So yeah. Okay, so for the they said that CAM in narcolepsy patients is common and comparable to use in CAM and other chronic neurological diseases in Germany. The high use of mind and body intervention may indicate if they're perhaps wanting a psychological well-being to be addressed. And then patients with high income or high education or a lower adherence to conventional medications, and those with spare time were more likely to use CAM. All right, and that concludes my journal club presentation. Is there any questions?
Suzanne, that was so great. I grew up in a very homeopathy alternative household. My mom was a homeopathic, is still practicing it. So I totally get the use of it. I mean, again, as Dr. Schutz was saying, it's hard to explain how people of higher socioeconomic statuses or higher education go for it. I don't know. I saw that even with my mom's patients, who she was kind of commonly seeing, but also a large part of it is the amount of time they spend with the patients. They do an intake for an hour or two. Follow-ups are an hour. A lot of the medications treat symptoms more than anything else. I need to understand it more. So, well, this is my mom will be very happy that they're finally coming out with studies on this, because she's a firm believer. So yeah.
I think it's good that they are coming out with studies, because I feel like some patients may be interested in doing this, and as our being their provider, we should be able to understand like what their motives are in using CAM, if it's helping or not, and to advise them accordingly.
Yeah, that was really great. Thank you. I was at the Narcolepsy Network conference, and I think the number one question that patients were asking is, do we have any research on nutrition and managing narcolepsy symptoms? And I looked, there really isn't anything. But people, and I think some of it may be a little patient autonomy. You know, with CAM, they have a little feel that they're controlling.
Yeah, exactly. And yeah, with the diet that you did mention, and when I was looking at the 5 domains, the vitamins and trace elements was one of the most used CAM. So I can see the correlation with that.
I had a comment, Suzanne. This was a great discussion. Thank you. I would have loved to see more from the authors, maybe exploring how phase of life may influence this. So at least in my clinic, the patients who seem to pursue these modalities are patients who are trying to plan a pregnancy, pregnant, or lactating. And that may also, explain some of the gender skew for this as well. So I think that would be something to look into the future. Because I wonder if that's part of it in addition to the other aspects that were explored.
Yeah, no, definitely. And yeah, that would make sense, especially since if they are pregnant, a lot of the current medications can cause a lot of side effects and may not be necessarily safe for the baby. So it does make yeah, I can see why more females may want to have an alternative option that is safe to use during pregnancy. So
I think I have more of a comment. I think this being a journal club, I think in terms of methods, the survey is also obviously always biased by people that are more interested in the topic than others, and that might have certain opinion and might skewed in a certain way, right? I think people that are interested in participating in this type of survey are probably the users more than the non-users more commonly, but I still think it is interesting and maybe speaks to some needs of the patients that medications don't address or don't address sufficiently, or where our usual toolbox could be expanded sometimes. And it reminded me of in the MS sleep clinic, Dr. Braley sometimes talks about CBTI for fatigue and how she has great results in her patients with that, right? So I think there's probably some truth in there, some grain of truth, and how effective the treatments are and whether or not they should be covered. That's a completely different discussion, but there seems to be something underlying that patients are missing perhaps with pharmacological treatments alone, or at least a subset of patients.
Yeah.
I think we might be hearing more from this group as well, because I think this was submitted as part of a thesis, right? And I think there's going to be more papers coming down the pipeline. So it's great. I mean, it's a descriptive study, it's just cross-sectional questionnaires, but you know, like we were discussing last night when we were, you know, preparing for this journal club. I mean, this is a step, right? That you can't go straight to the RCTs everybody likes to talk about and present. I mean, this is how they get started. And I think there's obviously, like, you know, like you've just said, a need for this. So I'd be interested to see where this kind of goes, and who knows, and, you know, in 5 years' time, we might be seeing a publication like this, but with like a, you know, a randomized control trial.
And I just put something in the chat, speaking to Shelley's note about nutrition. There's a funded project through the ASM Foundation. So hopefully we'll have some data in the coming years.
Great. All right, well, thank you very much. That was a great discussion. Thank you for the presentation, and we can end there. Five minutes to spare. Good job.
Thank you so much.
All right, thank you.
Thank you, Suzanne.
Thanks
Good
very
job.
much.
Thank you, Stan.
Thanks. All right, bye guys.